Well, the backstory behind BIOS was really a means to an end, right? A means to be able to help more people and to be able to help them in better ways. And what we've developed here is an institute. It's not just a clinic where we're not only treating patients but also doing research, doing translational research, and trying to bring it all together for folks. Biologics is a big part of it. That's what I specialize in. It's platelet-rich plasma, bone marrow concentrate. We also look at bioactive scaffolds and micronized adipose. And interventional orthopedics ties in very well with orthobiologics because it's a novel way or a more sophisticated approach with high definition delivery devices such as fluoroscopy, musculoskeletal ultrasound, even needle arthroscopy in some joints. So I am able to not only use those imaging modalities to diagnose, but then to very precisely deliver these biologics to the injured areas. And the last part of BIOS is sports and spine. And one is I am double board certified. One of my board certifications is in sports medicine. So we see a lot of various conditions, and not just orthopedics. We also do sports concussions and other sports related injuries. And we see quite a bit of spine. I'm very passionate about that. And I feel that that's an area that we've been missing quite a bit with orthobiologics. And I'm doing a lot of research and putting a lot of focus on how to get people's back or spine conditions better with orthobiologics. BIO stands for Biologics, Interventional Orthopedics, and Sports and Spine. So not only is it a cool acronym, but it really defines what we do and what we specialize here at the BIOS Institute. Interventional orthopedics is a novel and more sophisticated way to treat a certain amount of orthopedic conditions. For a long time, there was really only get a cortisone shot and physical therapy, maybe try a brace or take a bunch of pills, or have surgery. And now there is essentially a new wave or a new route that we're trying to bridge the gap, because there's a lot of people in this intermediate gap where those conservative therapies haven't worked. They're not really good surgical candidates, and they didn't really have any better treatments. But now with the development of orthobiologics and sophisticated delivery tools such as needle arthroscopy, such as musculoskeletal ultrasound, and even some nifty devices like percutaneous tenotomies, we're able to address a lot of these injuries that before had no solutions. At BIOS, we treat a pretty wide range of orthopedic and sports medicine conditions. I feel like if we divide them more into acute and chronic, so acute would be acute muscle tears, acute tendon tears, sports concussions, things of that nature. More chronic would be arthritis, for instance, hip or knee arthritis. We treat a lot of that too. And then comes more of the sports medicine aspect of it. For instance, acute sprains or sports concussions, things of that nature. And we really encompass that all together. We also see a wide range. We see kids that have sports injuries. We see a lot of professional and high-level collegiate athletes. We also see your weekend warriors and even geriatric population. So I think we're very good about honing in on what those age ranges are and providing specific therapies that better fit the need depending on what the patient's goals and situation is. I am the most passionate about orthobiologics. That's really what I love to do and I'm very passionate about. But it's not also the only thing we do, right? I think that we believe primarily on getting the right diagnosis first, no matter what that is. And we offer, traditional approaches. We offer conservative treatments. We offer things that have been tried and true, as well as the orthobiologic options. So I think for me, the main thing is to be able to provide options and educate the patient on what those options are. And then they can make a very educated decision as to what to choose. And there are times where these therapies may not work or are probably not going to work, and I think the patient would be better off having surgery, and we have some really good surgical partners that we can refer to and take care of that stuff as well. Let's take it from the beginning. What does it mean? It's platelet-rich plasma. So what we do is we obtain blood, we centrifuge it, and we essentially get rid of all the red blood cells. And then depending on the pathology we're trying to treat, we'll concentrate the platelets, try to remove or concentrate the white blood cells into a very, very small pellet. Then we deliver that pellet right to the site of injury. So there are times, for instance, in a partial tendon tear, that the goal of the PRP is to stimulate healing, right? We really are trying to activate the body's healing response to the area. There are other times, for instance, in, let's say, knee arthritis, where the goal may not be necessarily to regenerate or regrow cartilage, but more so to provide a strong anti-inflammatory effect that's going to last longer than, for instance, cortisone. Not only that, there's the hope for joint preservation, that by changing the environment of the joint, then we slow down the progression of the arthritis. But if we break it down to basic science, essentially platelets have these little alpha granules, which contain a bunch of growth factors and cytokines. So what we're really doing is when we inject the PRP, those platelets are being activated and they're releasing these high amounts of growth factors and cytokines, which activate the body's healing response to the area. So that's a great question. Is PRP experimental? And I think the answer is it depends. I think that for instance, knee osteoarthritis, we have a multitude of really well done studies, level 1 studies, that show a really good benefit in terms of pain and functional improvements that last for over a year. So for knee arthritis, no, I don't think it's experimental. For tendinopathy, for instance, common extensor tendinopathy of the elbow, which is tennis elbow, gluteal tendinopathy of the hip, also we have very well done level 1 studies that show that there's really, really good benefit. So for those types of conditions, I would say the answer is no. We have a lot of really good information that tells us, hey, this works, it's safe, and it's effective. There are other conditions, for instance, in the spine, that we still use PRP for, and some of the PRP derivatives, that data is still behind. So it doesn't mean it doesn't work. The studies just haven't really been done. And the studies that we have are small, and again, show positive outcomes. But I would say for that, maybe it is still considered experimental. So there's still a lot we're learning, but we've gotten to the point where we know a lot, and for certain conditions, by no means is it experimental. The most common injuries that we treat with PRP are number 1, osteoarthritis, number 2, tendinopathies, for instance, Achilles, patellar tendon issues, and number 3 would be acute injuries, for instance, acute ligament tears, acute muscular tears. But in those cases, it depends a lot on the situation, on what we're trying to accomplish. And lastly, something I've been very passionate about are spine conditions. Facet arthritis, disc issues, and sacroiliac pain we've been treating a lot with PRP. So bone marrow concentrate or bone marrow is really where blood comes from, if you think about it. So PRP or blood comes from bone marrow. So bone marrow, think about it almost as the mother source of PRP. So it actually has all the same things that blood or PRP will have, but in much higher quantities. So those same growth factors and cytokines that are present in PRP are in bone marrow, but just at much higher rates. There's also a small population of mesenchymal stem cells, which ends up being somewhat of a buzzword. I think we should think about this as bone marrow concentrate, not just a stem cell injection, because there's a lot more to it. Then there are certain proteins, for instance, interleukin receptor antagonist, IRAP, which is a protective protein that we can inject into joints that's in very high levels in bone marrow concentrate, and will not only provide an anti-inflammatory effect, but also provide a protective effect. So for me, bone marrow concentrate is just much stronger platelet-rich plasma. For me, higher grade partial tendon tears. PRP a lot of times isn't strong enough to treat these. Therefore, we have to come with a stronger product, and that's where bone marrow concentrate can really help. Also, when we look at earlier stage osteoarthritis, we used to be all about just injecting the joint and that's it, but now we also know that there's problems underneath the cartilage as well, in the bone. So for instance, let's say a patient that has mild to moderate arthritis, we look at an MRI, they also have a lot of inflammation in the bone. That's where I feel like bone marrow concentrate is a really good option, because we not only inject it into the joint, but we can deliver it into the bone as well. So an intraosseous injection, and help heal that bone as well. So we have primarily 3 image-guided techniques. The first one is musculoskeletal ultrasound. I've been using that for quite a while. And that is a great way to be able to not only localize pathology, but guide needles or tools directly to the point of directly to the source of the problem. For instance, for a long time, joint injections, we've just been trying to find the joint and guide a needle, or into a tendon, we palpate around and kind of find the most tender spot and then stick the needle. That's a little bit barbaric, I think, these days, and with musculoskeletal ultrasound, you can very, very precisely guide a needle gently and directly into the spot, which, number one, will create less procedural pain, will be essentially 100% accurate, and therefore deliver that therapeutic agent directly to the spot. Fluoroscopy is live X-ray. For spine conditions and for things that might be a little deeper down, we want to use live X-ray so we can guide needles very precisely to those spots. Also, for instance, I mentioned the intraosseous injections. Once I get to the bone, I can't see any further if I'm using ultrasound. So in order to see inside of the bone, or seeing the tool advance inside of the bone, I have to use fluoroscopy, which is the live X-ray. And lastly is needle arthroscopy. I use that primarily for knee, where kind of a combination of both. I can't see inside of the joint with ultrasound, and I'm looking at soft tissues inside of the joint, for instance, your ACL or your meniscus, or things of that nature that are soft tissues. We can't see them with ultrasound, we can't see them with X-ray. Now we can advance this needle-sized camera inside of the knee, identify where the problem is at, and guide a tool directly into it. So if your provider isn't using musculoskeletal ultrasound, there's a few issues. Number one is they are not going to be able to truly identify pathology unless they're potentially getting an MRI or doing some more advanced imaging. But a lot of times we can give you the same answer right on the spot. Number two is it's all about precision and accuracy. So whenever you're doing even just a basic injection, you want to be able to make sure that you're 100% accurate every time, right? You want your pilot to land the plane every time, right? So 90% isn't good enough, 85% isn't good enough. You want to be 100% accurate, and musculoskeletal ultrasound allows you to do that. Every time, guide the needle very precisely to the spot. Not only are you going to get a better outcome, two, the risk of me harming you is much less because I can see all the structures. And number three, the pain from the procedure itself will be much less. Well, treating high-level athletes, you learn a lot. Those guys really like to push the envelope and they need results quickly. And therefore, we have to implement more aggressive strategies at times. But I think it also it opens the door for you to be able to do different things, and it challenges me as a physician to really be the best that I can be at all times. But what it also does is that it allows me to give everyday people those same types of therapies. Because for me, it's all about treating everybody equally, whether you're a super high level athlete or you just need to walk around without pain. The difference is that I am challenged to make somebody the best I can in a very short amount of time. So I've been able to implement those strategies and now take them and give them to other people as well. Number one, obviously we're going to look at lifestyle, right? So we always want to promote healthier lifestyle, weight loss. We look at supplements like glucosamine and collagen. Then I think physical therapy is very important. You want to strengthen the muscles around the joint to provide protection and support, and build endurance so that the joint doesn't have to take as much of a load. Bracing can also be an option. From an injection standpoint, the mainstay has always been cortisone. We're actually not big fans of that because it can harm the cartilage more than it can actually help. Two would be hyaluronic acid injections. That is essentially a gel that's going to lubricate the joint. Number three are platelet-rich plasma injections, which fall under the orthobiologic category. Those are great at providing pain relief and trying to promote cartilage preservation. And a step from that would be bone marrow concentrate. We can also use micronized adipose in some cases to provide a similar effect. The key thing is to understand that a lot of these orthobiologic options are going to work better in earlier stages, and the expectation should be correct. If you have bone-on-bone arthritis, we're not going to unbone on bone, right? But we can provide a really good anti-inflammatory effect and hopefully give you functional and pain improvements. Physical therapy is very important. I think that a lot of times people don't realize when you have an injury, you're going to protect that injury even subconsciously. So your muscles aren't going to fire at the same rate that you would otherwise, and that muscle is going to become weaker. The endurance of the muscle is also going to go down. You may also be doing some compensatory things, maybe changing the way you walk, maybe changing the way you do things that could create injuries in other areas. So if you haven't had physical therapy, it is a good point to start to see if by nurturing the joint, trying to open up the range of motion, looking at the range of motion above and below it would really help. And then from there, start to strengthen. If we do an orthobiologic injection, it's almost like we're hitting the reset button, right? We're activating the body's healing response to the area, and that's going to take a few weeks to really kick in. So therefore, we also like to add physical therapy on top of that to strengthen, make sure that the range of motion is good, and that functionally we're correcting some of the imbalances that he had before the injection. So the typical tendon treatments that we have are, number one, platelet-rich plasma. We inject either in a bathing pattern just to provide an anti-inflammatory effect, or we inject directly into the tendon. That's more painful, takes a little bit longer to rehab from, but that's a better way to actually get the tendon to heal. Alternatively, we have percutaneous tenotomies. There are several devices that we can use for that. And the idea there is to try to break down that negative scar tissue that builds within the tendon, provide a better bed, if you will, for the PRP to go into. Very much like with the other treatments, we can use bone marrow concentrate, micronized adipose, and even allograft amnion sheets or amnion membranes that we can deploy inside of the tendon as a scaffold and combine them with platelet-rich plasma or bone marrow concentrate. For spine conditions, we have several options. Number one is obviously getting the right diagnosis. If I feel that it's coming from the joints, for instance, your sacroiliac joint, your facet joints, platelet-rich plasma injections are a good option to try to treat that type of pain. If you have discogenic pain, for instance, an annular tear in the disc or a smaller disc herniation, then we can inject directly into the disc, whether it's with platelet-rich plasma or bone marrow concentrate. That's a little more of an advanced technique that takes a little more rehab time, but it's certainly something that we can do. And for epidural injections, what I do is actually create platelet lysate with a technique that I developed using autologous thrombin, where we actually activate the platelets outside of your body to make sure that nothing harmful happens when we inject them. So those are three really good orthobiologic options for the spine.